Assalamu alaikum. Now we are going to complete the previous lectures about the review of system. After we discuss the cardiovascular system, the respiratory system, the gastrointestinal, then now we are going to discuss the urinary system, review of urinary system. And you have to ask about the main presentation or main symptoms of urinary system or genital urinary system. For example, dysuria, polyuria, oliguria, anuria, hematuria, frequency of urination, urgency, hesitancy, loin pain or flank pain, puffiness in the face, urethral discharge, nocturia, and urinary incontinence. So these are the main presenting symptoms of urinary system. Dysuria, which is feeling of burning micturition, and tingling sensation felt at the urethral meatus. Urgency is a sudden and an immediate unstoppable urge to urinate due to sudden involuntary contraction of the muscular wall of the bladder, which is commonly occur in elderly people. So it is a sudden and immediate urge to urinate. This is urgency. Hesitancy is a poor stream urine with difficulty in initiating micturition and in stopping it. Also occur in elderly, especially male with prostate, for example, and the condition associated with terminal dribbling. Polyuria is frequent amount of urination daily exceeding 3 liters per 24 hour. Oliguria, when the amount of urination is less than normal, which is usually less than 300 cc per 24 hour. And anuria if it is less than 50 or some say 30 milliliter per day. This is anuria. And polyuria, for example, is one of the presentation of diabetic patients or diabetes insipidus or diabetes mellitus. Oliguria and anuria may occur associated with kidney problems, for example, glomerulonephritis or acute renal failure. Now, important presentation of urinary system is hematuria. So let us discuss the causes of hematuria. And hematuria is the appearance of blood in the urine. So the urine looks red and bloody. And the reason of hematuria is either due to kidney disease, for example glomerulonephritis, like primary and secondary glomerulonephritis, or it may be infection of the kidney, pyelitis or pyelonephritis, papillary necrosis, condition associated with sickle cell anemia, or in diabetic patients, or when patients using a lot of non-steroidal anti-inflammatory drugs. We call it analgesic nephropathy. Malignancy of the kidney may associate with hematuria. Cystic disease like adult polycystic kidney disease or medullary cyst disease, and stone or trauma to the kidney, blunted trauma, car accident, bullet injury, patient may present with hematuria. Ureter problems may be presented with hematuria, for example neoplasm or stone in the ureter, usually associated with hematuria. Bladder, urinary bladder, tumor of the urinary bladder, infection of urinary bladder like cystitis, stone in the urinary bladder, bilharzia disease or schistosomiasis. You have 3 types of schistosoma. We have schistosoma mansoni, schistosoma hematobium, which is in our country, especially in the south of Iraq, and patient usually presented with hematuria due to cystitis, involvement of urinary bladder. Trauma to the bladder, either blood trauma, accidents, or even during some sort of procedures, for example, cystoscopy, or even during catheterization of the patient. Number 4, prostate, like tumor of the prostate or prostatitis. Urethra, even urethral infection like urethritis and trauma to the urethra during even certain procedures or even catheterization. Bleeding may have hematuria. Patient may have hematuria due to bleeding tendency, for example, blood dyscrasia, blood disorders, or anticoagulant chemotherapy. Drugs may lead to hematuria. So these are the causes of hematuria: kidney involvement, ureteric involvement, stone or tumor, bladder, tumor, stone, TB, infection, cystitis, prostate, and urethra. So these are the main causes of hematuria. Differential diagnosis of hematuria: not any patients with red color urine is hematuria. It may be hemoglobinuria when there is massive hemolysis, myoglobinuria in cases of rhabdomyolysis, bilirubinuria in patients with obstructive jaundice, acute intermittent porphyria, and drugs, for example, rifampicin may cause red color urine, dye, special type of dye, phenylethylamine, beetroot, and senna. So certain types of food may be associated with hematuria or red color urine, acute intermittent porphyria, bilirubinuria, myoglobinuria, hemoglobin, all these causing a red color urine or colored urine. Is not normal urine, colored urine. The color of the urine, normally it is a straw in color. It may be colorless, pale, especially in dilute urine, overhydration with low specific gravity. It may be deep concentrated urine when there is dehydration, or patients may have jaundice in bilirubinuria. Orange red urine like in hematuria or hemoglobinuria. Brown black in myoglobinuria, usually the color is brown black. Milky white in patients with turbid urine or infection, we call it pyuria. Orange, certain drugs like oxytetracycline, rifampicin, and etc. So these are the colors of the urine. Could be normal, hematuria, jaundice, hemoglobinuria, and myoglobinuria. Now discussing the review of central nervous system. Central nervous system have many symptoms. The majority of cases of CNS presented with headache and facial pain, which is very prominent and very common in our clinical practice. Patient may present with weakness, let us say left-sided or right-sided weakness, upper, lower limbs, or sometimes he may have paraplegic. All the limb is paralyzed. Fit, epilepsy, convulsion, vertigo, dizziness, speech disorders, visual disturbance, hearing disturbance, mental state, cognitive function disturbance, syncopal attack, and coma. These are the main presenting symptoms in the patients with CNS disease. Headache, as I said, one of the most frequent neurological symptoms encountered in primary care and hospital practice. So it's common. A lot of patients presented to you complaining from headache. And you have to localize the site of pain. Is it frontal headache? Is it occipital headache? Is it headache felt all over the cranium, for example? And headache may be acute, few days or hours, or it may be chronic if the duration takes about several weeks. Sudden and severe headache of acute onset may be serious, for example, subarachnoid hemorrhage. So keep this in your mind: sudden and severe headache. This is subarachnoid hemorrhage until proved otherwise. Just like in chest pain, when I told you that sudden and severe chest pain, this is pneumothorax or dissecting aneurysm or massive pulmonary embolization. So the important reason for sudden and severe headache is of acute onset is subarachnoid hemorrhage. The cause may be divided to primary, so we have primary headache and we have secondary headache. Primary headache syndrome is caused over the activity. Why patients develop a primary headache is caused by overactivity of the pain-sensitive structures. So it's an overactivity in the head, and the causes of primary headache may be due to migraine, with or without aura, tension headache, trigeminal autonomic cephalgia, or trigeminal neuralgia, cluster headache, which is part of the migraine, cough headaches, exertional headaches, sex-related headaches, new daily persistent headache syndrome, and thunderclump headache. These are the important causes of primary headache. Number one, migraine, with or without aura. I forget to write aura, which is the preceding symptoms of headache. Some primary headaches can be due to lifestyle factors, including alcohol, just like red wine may present with headache, certain types of food, change in sleep or lack of sleep. All of you may have headache when there is lack of sleep, deficiency of sleep, poor posture, skipped meal, and stress. Secondary causes of headache. A secondary headache is a symptom of a disease that can activate the pain-sensitive nerve of the head. Example of secondary headache, like due to medication overuse. For example, those patients with medication overuse may have a rebound headache caused by overuse of pain medication. Second, intracerebral hemorrhage, for example, subdural hematoma, subarachnoid, or intracerebral hemorrhage. Raised intracranial pressure due to space-occupying lesion, for example, brain tumor or idiopathic intracranial hypertension. سابقا كنا نسميه benign intracranial hypertension, now IIH. This is idiopathic intracranial hypertension. Infectious causes of the meninges, meningitis, encephalitis, and brain abscess. Inflammatory causes like acute sinusitis, ear infection, influenza or flu, or vasculitis. Referred pain from other structures like orbit, in patients with glaucoma may have severe headache. Temporomandibular joint, patients with rheumatoid arthritis. Neck problem, carbon monoxide poisoning may have headache. Glaucoma, increased intraocular pressure. Hangovers. What's hangover? It's a severe headache or other after effects caused by drinking an excess amount of alcohol. High blood pressure and ice cream headache, commonly called brain freeze. These are the important causes of secondary headache. The second important symptoms of central nervous system is syncopal attack. Syncope. What is syncope? It is an acute cerebral hypoperfusion causing loss of consciousness. مرات نجيب لكم سؤال. Define syncope and write or mention the important cause of syncope and give an example. So definition of syncope is a acute cerebral hypoperfusion causing loss of consciousness due to inadequate blood supply to the brain. So there is inadequate blood supply to the brain. Why? Due to sudden vasodilation or due to sudden fall in cardiac output, or could be both. So both sudden vasodilation and sudden fall in cardiac output, or both may lead to inadequate blood supply to the brain and patient may lose consciousness, brief loss of consciousness. We call it syncope. Sudden vasodilation, for example, due to antihypertensive vasodilator drugs. So it can cause sudden vasodilatation, which occur in postural syncope due to vasodilator drugs. Sudden fall in cardiac output occur in patients with complete heart block, like for example in patients with inferior wall myocardial infarction, he may have complete heart block and tachyarrhythmias who may develop cardiac syncope. Exertional syncope and those with severe aortic stenosis, ischemic or hypertrophic obstructive cardiomyopathy. Syncope is preceded by a brief feeling of lightheadedness. Usually, during syncopal attack, most patients they mention that they have a brief feeling of lightheadedness before the attack of syncope. Neurocardiogenic syncope or vasovagal syncope. This is very common syncope type of syncope occur due to reflex cardiac slowing. So the patients have overstimulation of the vagus nerve causing bradycardia associated with sudden withdrawal of peripheral sympathetic tone leading to fainting attack and bradycardia, which is more likely on standing and may be provoked by pain or emotion. And sometimes when you want to give an intramuscular injection to a patient rather than fainting yoga, there may be darkening of vision, ringing in the ears, hyperventilation, distal tingling, feeling of nausea and clumsiness or sweating. So this is very common. We have a lot of patients during the certain emotional stressful condition or certain painful situation. Patient may have loss of consciousness, brief loss of consciousness, and vasovagal syncope due to overstimulation of the sympathetic with vagus nerve causing hyperstimulation causing bradycardia. The loss of consciousness is gradual and brief, and the patient recovers quickly without confusion as long as she or he has assumed horizontal position. But once you have a syncope in any patients, immediately you have to put the patient on the bed, تنام على سرير أو بلقاء وترفع رجليه, and immediately and quickly he will regain his consciousness and recover without a remarkable neurological defect. Coma, another important central nervous system symptoms. Coma, definition of coma is a loss of awareness both of self and environment. So there is loss of awareness of both self and environment due to defect in normal cerebral activity. The first priority on examination is an assessment of cardiac and respiratory function. Then once you receive a patient, when you are in the casualty, in the emergency department for example, and they brought you patients in a coma state or comatose, you have to maintain immediately breathing and circulation. So these are very important. Immediate maintain circulation and breathing. And conscious level should be measured using the Glasgow Coma Scale. What are the causes of coma? Coma may be due to metabolic causes or structural causes. Metabolic causes of coma, for example, drug overdosage. Any patients use large amount of certain types of drug. For example, in suicidal attempt, he may lost his consciousness. Drinking alcohol, especially in huge amount, patients may present with coma state. Diabetes per se may cause coma when patients develop hypoglycemia or hyperglycemia, ketoacidosis, hyperosmolar non-ketotic diabetic coma. أيضا ممكن نسوي لنا loss of consciousness and coma state. Hyponatremia, renal failure, uremia, hepatic failure, respiratory failure, hypothermia, hypothyroidism, thiamine deficiency, and hypoxia, hypoxic encephalopathy. We saw a lot of cases, especially in post-operative room, when they want to recover the patient from anesthesia. He may have a delayed in the recovery from anesthesia, and those patients went into a coma state. And one of the explanations that they may have a hypoxic encephalopathy, hypoxia. Keep this in your mind. Structural causes, so either metabolic causes or structural causes. We mentioned the metabolic causes. Now the structural causes, either due to trauma, for example, cerebral contusion, extradural hematoma, subdural hematoma, or maybe infectious causes like meningitis, encephalitis, cerebral abscess, and even systemic sepsis. Vascular disease like stroke, maybe due to subarachnoid hemorrhage, brainstem infarction, or hemorrhage and intracerebral hemorrhage. So a patient may present it to you with stroke or CVA, and the first presentation of stroke may be loss of consciousness and coma state. So it may be traumatic, infectious, vascular, and others. Others like epilepsy, brain tumor, and functional, like pseudocoma. This is the Glasgow Coma Scale. We have the total score, the best score when it is 15 and above. If it is comatose, if it is 8 and below, this is a comatose patients. If the patients 3 and below, this is unresponsive. We have the behavior and we have the response. Eye-opening response and verbal response. Then you have to do a motor response. وتحط النقاط وتشوف السكور مال هذا البيشنت. تقول جلاسكو كوما سكيل مالته 10 مثلا. جلاسكو كوما ستيل مالته 12 for example. Locomotor system, review of system. وصلنا للlocomotor system. In locomotor system we have to ask about the joint and bone and muscle. For example, arthritis, when there is swelling in the joint, or sometimes even pain in the joint, we call it arthralgia, or tissue swelling, especially in patients with connective tissue disease, rheumatoid arthritis, for example, systemic lupus, scleroderma, disability with the degree of disability. So you have to ask about the disability and the degree of disability. Bleeding inside the joint, for example, in patients with hemophilia, for example, you may present with hemarthrosis. Hemarthrosis is bleeding inside the joint. Pain and stiffness of the joint, especially in early morning stiffness, for example, in patients with rheumatoid arthritis, very significant. Deformities in rheumatoid arthritis and even in diabetes, we have a lot of deformities. Claw foot, for example, Z nail deformities, boutonniere deformity, or swan neck deformity. A lot of deformities you may see in the clinical practice, especially in patients with rheumatoid arthritis or other connective tissue disease. Now we finished the review of system. Thank you very much.